And what I see the most common is that people come to us and vendors would come to us and want to do the more profitable side, right? They want to do ACA and they want to do Medicare, but they don't want to do Medicaid. And so that's been frustrating to me to be able to offer services to some members, but not others. And so I've worked really hard to teach companies that you can innovate inside of Medicaid. And if they will engage in a dialogue with me in a whiteboard session, we can figure out the ways to start to work their way into Medicaid along the way. And so that's probably the biggest myth that I see is that you can't innovate inside of Medicaid.
Welcome to another Meeting of the Minds with Wobot Health. I am your host, Chris Hemphill. We are ready to dig in deep on myth busting in Medicaid, challenging existing assumptions that are holding organizations back from best serving their Medicaid members. But before we get into it, got to apologize. Have to apologize because the audio and video didn't turn out the way that we would expect, but we're posting this anyway because the conversation was so great. Tracy Rico, who is the Director of Virtual Care Services at Centene Corporation's Superior Health Plan, started her journey as a Medicaid member. And she goes into that story and the frustrations, how she felt lost in the system, and how that's ultimately translated to the work that she's done as she's evolved her career into nursing, into care management, and ultimately into leading technological innovations for Medicaid members. So really eager to get into this with you. Sorry about the audio video, but the conversation makes up for it. Thank you. I wanted to start by actually thanking the Going Digital Behavioral Health Tech Conference. Actually, we were planning to do this as a podcast there, but we ended up we weren't able to meet. Schedules didn't cross, and Tracy fell ill, so we had to do it here online, which is also awesome. So we're not mad at that in the slightest. But just wanted to thank Solomay and team at Behavioral Health Tech for helping us to facilitate this conversation and make it happen. Now, getting into it with Tracy and going deeper on this gap between what health tech is doing and the needs of Medicaid members and our populations out there, it's just really excited to speak with her because this isn't someone who's a talking head. This is someone who, if look at her LinkedIn profile, it says fierce patient advocate. So we're going to hear a lot of that passion come through. And she shared also that she was a member of Medicaid herself. So we're getting this is leadership and passion that is informed by experience, and can't be excited enough to welcome you to talk to this audience today, Tracy.
Thank you. I appreciate it. And thanks to Salome too. She threw a magical conference where I got exposed to all kinds of fun new programming, and I can't wait to go again.
That really was a magical conference. And honestly, just to get the conversation started again, overall, what we're about to get into it, the main goals that we have here are to help break down some of those myths, like identify what are these myths that are holding us back from developing and doing effective outreach for our Medicaid populations. What actually is holding us back, and what are some of the practices? What are some of the ways we can rethink the way the way that we're doing? What can we look for in 2024 and 2025 to think about innovating for these populations? So breaking down those myths is one aspect, but again, Tracy, who's been in this role for over 10 years, we have her here to discuss and lead by example and share, maybe borrow a little bit from her strategy and thinking. So getting into it, Tracy, can you start with your personal story and what's led you to devote your career to that intersect of health tech and Medicaid?
For sure. So, hey everybody, nice to see you again if I've seen you before. I'm Tracy. My background is when I was first starting out a family, I was still in college and getting most of the way through it. And I decided in my innate wisdom as a as a 20-year-old that I should start a family at the same time. And so I actually had Medicaid. My first experience with Medicaid was through my pregnancy. and then with my young children. And so I've been on the receiving end of this side of the story for a long time. And so I knew what it was like to try and interact with an MCO, to look for programming that helped me, to be a part of what gets paid for and what doesn't. And so I really understand the patient perspective. And then as things progressed, my kids continued to have some chronic things going on with asthma. And I got frustrated with the healthcare system and not knowing what to do, like what the navigation behind getting through the healthcare system was, and finding the right people to really take care of my kids the way that I wanted them to take care of. And so I went back to school and I decided to switch and become a nurse instead so that I could take care of my kids and pick the right levels of care for them on my own. I did that for several years. I did some labor and delivery. I did some pediatric nursing. And then I got to see what it was like to help patients that had Medicaid. And then from there, Centene called one day and said, hey, how would you like to try doing something on the administrative side? And I was like, what? Maybe so. And it gave me the opportunity to go from helping one person at a time to helping millions of people at a time, which was really freaking cool. And so this is casual Tracy. Sorry if you were expecting corporate Tracy, I don't have one of those.
I couldn't find corporate Tracy.
My first role within Centene, I served as a case manager. And so I got to feel what it was like to be on the administrative side, but actually like trying to get a hold of numbers on the phone and trying to work through the fact that demographics are wrong more often than they're right, coming from Medicaid agency. And so I got to try to reach members and get frustrated by all I could do was make phone calls and send postcards and hope that people called back. And I didn't feel it like I was really, really helping as much as I wanted to help. And so one day they asked me if I would go speak to the March of Dimes about what we did. And I did. And I was with a member of our ops team, our ops team. And they were like, and I was telling them, I'm like, doctors don't know that we do what we do, right? I mean, I'm talking to pregnant members. Their obstetricians would benefit from knowing the programs that we can offer their members, and we would benefit from knowing what's going on with their pregnancies. So we really, as nurses, can understand what those members need and help translate. And she mentioned, hey, like we were thinking about putting a nurse on the ops team. And I was like, huh. I was like, is it like a drug rep for case management? And she was like, yeah, well, it could be. And so we had those conversations and we decided to move forward. And so we built out the first clinical nurse liaison program. That was essentially what started as a drug rep for case management and for MCOs became an education program for physicians to teach them how to interact with us, how to work with us best, how to support your members, what programs are available, that kind of thing. And then along the way, we started like taking out reporting that was about, your ER, your member, these are the members that were 120 days ago were in the ER. Can you like help them understand that there's other levels of care, like you're available after hours, or there's urgent care, or for things like strep throat, right? And so I would get the physicians would tell me, hey, this data is really old. How do we like act on this? You want me to call Tracy, who had a strep throat 90 days ago, and see if she finished her meds? Like, what do you want me to do with it? And so I fell in love with health information exchanges and 24-hour, delays on data as opposed to 90 to 120 days delays on data. And so I had a great time doing that for a few years. We built out some alert programming to let providers know when their patients have been in the ER or in an IP stage, so they can do follow up with them. We built out automation for some prior auths based on ADT data. We built the relationships with all of the health information exchanges in Texas. And then that kind of progressed, and suddenly telehealth became a thing. And I'd been waiting for telehealth to be a thing for so long. It wasn't payable. When it was finally payable, I was like, let's do this. Like all the things, right? Let's break all the barriers that everybody has to get to their appointments and really be able to help people where they're at in the moment that they're at without causing them to lose income because they have to stop and go to the doctor's office or they have to leave to pick up their child from school. And so I started building out that relationship. This is super public, so I can say this. We have a relationship with Teladoc. And then I've spent the last 4 years building out the programs that are more specialized and more high touch and focused on specific disease states, not necessarily an urgent care solution or an adult BH solution, but beyond that. And so I've had the best time meeting with companies and co-designing projects that work for us as a payer, that help members and that providers will tolerate. I'm excited about that and looking forward to what's coming next.
Well, thank you for sharing that detail, because I think that it's really powerful to start from a position of being frustrated by the lack of options available, and then moving into a caretaker and care delivery role. But it's so important to recognize that if you're distant from having a healthcare professional closer in the family, then it really hurts your ability to navigate through the healthcare system. So to hear from you, who has gone through this journey in terms of also like the next step when we talk about navigation, case management, all the way to leading these technology initiatives, in spirit of the theme of the webinar, Medicaid Mythbusters, can you talk about some of the harmful assumptions that you may have seen on the way, and what some of the most important myths are to bust?
Sure. So Centene as a whole has three major lines of business. It's the ACA market and better, Medicare and Medicaid. People come to us and vendors would come to us and want to do the more profitable side, right? They want to do ACA and they want to do Medicare, but they don't want to do Medicaid. And so that's been frustrating to me to be able to offer services to some members, but not others. And so I've worked really hard to teach companies that you can innovate inside of Medicaid. And there's no budget for innovative programming. And that's not true. Is there a ton of money? No. But is there opportunities that if you co-create a project and that targets specific members that are on the higher spend level, and you can design a service that works to lower that cost, all we really need is, and I'm going to get hurt for this comment, but the thing we really need is that we need to be able to pay for it, right? If you can save enough money to pay for it, then we can innovate with you.
I think that it's important that people start thinking about how how that fits into the ethos. So it's not a matter of everything being completely static. It's a matter of really seeking ways to enhance these patient experiences, but at the same time help reduce the cost burden and unnecessary burdens to those same patients, right?
Yeah, I mean, we need to innovate, right? I mean, you can't help people if you never change anything, right? The progression of diseases is outrageous. The volume of people showing up with comorbidities is just horrific, especially in the mental health space in the last few years. Like, if you don't continue to innovate, you aren't helping enough people.
Moving a little bit deeper into that thought, just wanted to think about other myths that you might have seen as holding healthcare leaders back and holding innovators back. And I wanted to couch it kind of in terms of kind of a rapid fire, like what's the myth and then what's the reality?
So another common myth is that people with low income or disabilities can't use health tech. And they won't have access, they won't be able to use it, they won't have the devices to support it, they don't have the aptitude for it. Like, none of that's absolutely true, and that's changed dramatically. And this is a strange comment, but COVID was the silver lining of COVID was every grandchild taught their grandparent how to do this. And now they have devices, and now they know how to use them, and now they've been exposed and they're not intimidated by them. So many more people are engaging in technology that they wouldn't have engaged in before, and trusting it. That was the trick, right? They had to see a kid do it, and that helped expose them. And then they were so motivated to continue to be able to see their babies, and grandbabies during this time. They really got into technology. And so we haven't, everyone warned me when I started doing programs like this, no one's going to use it. Your utilization is going to be like 1%. That's not true at all.
That's a myth that's pervasive with with the Medicare population as well, is assuming that people can't use this technology. I will actually accuse myself of being guilty of that myth before I started looking at the data. Like when I'm not podcasting here at Wobot, I help with healthcare data science, and looking at patterns, like engagement patterns within the app. Our 65 plus users, we just saw tremendous usage and retention even higher than lower age groups. So definitely should be looking past that concept.
Mm-hmm.
Major important myth. It's really painful to hear just that idea that people have this assumption that because of a certain financial class and resources available, people can't use technologies. Did you have some other ideas too in that kind of myth versus reality framework?
So further out, like people will often say that not only can you not access them, but they won't understand how to use them or won't want to continue to develop them. I think that the way that you roll things out in a program like that is what's really important. So what I do when we run programs like this is we don't just send out devices. We don't just send out programming. We don't just advertise, an app through a mailer, right? We teach, I spend a lot of time internally teaching our case management staff, our member facing staff, our community resources staff on what these programs are. I give them access so that they can see what it's like to experience them. I try them myself, and anybody else who wants to try them, we get them an account. We let them try the services so they fully understand it, so that you can see one, do one, teach one. When we send out programming, we make sure that we're doing a whole bunch of education along with it. We're teaching health literacy, we're teaching digital literacy, we're asking important questions like, hey, do you have access to a device? Do you know where you can go? What public places are available? We actually surveyed, last year we commissioned a survey of 5 remote counties and trying to decide, hey, do people really not have broadband access that's good enough? Can you do a quote unquote teledoc visit by video in random places? Most of those people could. It wasn't a concern about if they could, it was more a concern about comfort level with it. And so we allow for audio only, with especially behavioral health visits, so that members who aren't comfortable with the I don't love being on video myself, but I do it. But on when I'm meeting with a physician, a lot of times I'm in pajamas with my hair everywhere, when I do my telehealth visits, so I don't particularly want to be on video. So if people are nervous about being video worthy, then they can do audio only, and that takes away also some stigma, by the way, of behavioral health visits. And so if you allow for lots of ways to connect, you do this low tech, low bandwidth solution that's really high touch and has humans backing it, going, hey, as your case manager, I can tell you I played with this thing. It's pretty freaking cool. You should do it. It's really educational. And we have a lot of our programs involve coaching, so that there's someone who, when they make the phone call or they download the app, there's someone who can say, hey, this is where you click within the app to get where you're going. This is how you set up an account. This is, all the things. And so we actually took the time last year to also do, we created videos for our members and for our providers, so that, because one of the other things we learned in those surveys is we asked every provider in those counties, what's up with telehealth? Do you not like it? Will you continue to do it after COVID? Was it only a necessity? Is it something that, what are the barriers around it? What are you afraid of? Things they're afraid of is that they won't get paid. They don't know how to work it into their workflow. They don't really understand telehealth bedside manner, all of those little things. So we had the University of Texas has a professor that teaches all things telehealth. And so we had her create a series of videos. There's 4 for providers, and then there's 4 for members in English and 4 for members in Spanish, that teach you all the basics. We call it Virtual Care 101, so that people feel prepared. Hey, if a case manager is talking to them and they're like, hey, you can do a telehealth visit, they can say, hey, the member will say, hey, I don't really know how to do that, or I don't understand it, or I don't trust it. They can refer them to these videos. And then after they go through the series of videos, they're much more likely to have that higher digital literacy that allows them to participate in programs that increase their healthcare literacy.
The way that you frame this program makes me think that we do ourselves a disservice if we put a wall around, hey, these are the ways that you just increase experience for Medicaid members, because really everybody can benefit from that hand holding and guidance when it comes to adoption on the clinical side, on the on the patient side. So I really love that frame up, because the things that you're talking about don't just apply to one population, they apply to everyone. So I guess getting into it too, we're exploring these myths, and we're exploring these concepts. But it makes me wonder about the experience and what you drive at as a result of addressing these. So just thinking, maybe borrowing from your experience, maybe giving people something a little bit to plagiarize on. Can you talk about your strategy and goals for 2024 and 2025, kind of in the context of, hey, we've explored some of these myths. What are we going to be doing this year to address the needs for our Medicaid populations?
Continuing in the vein of navigation, we are actually piloting a couple of things. So we just went through, and by the way, my biggest advice for digital health people who want to start working in Medicaid and need to know where to find some funding, follow RFP cycles. We have to bid for every few years for each line of business that we have to the state, right? And that determines how many more people we get to serve or how many less people we get to serve. And so in those moments, we're actively looking for programming that's more updated than we've had historically, so that we can better take care of these members and prove to the state that's reading the RFP that this is the place to do that. And so following that vein of navigation, we are actually piloting a program that is called CAS. The company's called CAS AI. It's the first time that I'm doing anything in an AI space, so fingers crossed. We're going slowly and carefully. We're doing a small pilot for members that have just left the hospital that had a mental health diagnosis. And so they need to follow up right away. But oftentimes anyone who leaves the hospital, one, is completely overwhelmed and exhausted, period. No matter what you're there for. It's not a grand experience. and you're not at your finest in that moment. And so thinking through how hard healthcare navigation is when you're healthy, it's so much worse when you're just being returned from a hospital. And so we are having them outreach CAS's, the AI chatbot mental health assistant. They reach out and they say, hey, every single day they have a new list of members that left yesterday because of the data projects that I've done historically. They say, hey, Tracy, we hear that you were just released from a hospital, and we know we would like to help you with any follow-up care that you might need. Do you have a provider? Yes or no? If you say yes, great. Can that provider see you within the next 7 days? If they say no, then they suggest our Find a Provider. They walk them through it. They suggest our virtual care provider partners. They walk them through it all the way down to they can help make an appointment directly. And then once they find out that the member has that appointment made, they do appointment reminders 1 day, 3 days in advance. And then they follow up afterwards and they ask how the visit went. And, if they have any questions or concerns, and throughout the process, not only did they teach them how to navigate and how to get them in front of a provider when they need to be in front of a provider, so that they won't have to go back to the hospital, because no one wants that. They also do screenings, BH screenings, like for anxiety and for depression, so that they can give us that data back and let us know how patients are doing, and if their acuity level has changed to a degree where they need a crisis counselor. They can route directly to our crisis counselors, and then they also can route back to our behavioral health case managers to let us know, hey, we need somebody to see them like today. And so I'm really excited to pilot that. It's got a conversation behind it. It's trained by BH clinicians, it's peer-reviewed, studied, and all the things. And so I'm really psyched. It's only been live. Today is 2 weeks. And so far, members are staying engaged with it. Like, they have over 40, 50 plus messages. And so they haven't been bothered by the fact that it's a bot. They're excited that someone wants to talk to them about what's going on, and somebody's trying to help when they don't feel like maybe anyone's trying to help. And so I'm really excited about that. That, like I said, just launched. We're going to see how that one goes. And then on the data side, We're about to launch a company. We just signed the contracts yesterday, called Watershed Health.
Mm-hmm.
And this gets to the nurse in me, right? So I remember as a Medicaid member trying to understand, where do I go for help, right? Like, my kid just got released from the hospital and I don't know what all these medicines are. I don't know where to go get them. I don't have transportation to go get them. I don't have, and by the way, I don't have enough food. So I'm not super psyched about having to figure that out. I'm figuring out what to feed, right? What to feed people in my home. So what this program does is it creates a healthcare ecosystem with the patient at the center, which is one of my favorite words right now. and so it's a communication platform where the entire ecosystem around a patient can actually interact with each other and see who's doing the services they say they're going to do. So Tracy's kid left the hospital yesterday. While they were there, they filled out an SDOH survey that said she had these 4 needs that need to be met, right? No one agency, including us, can provide all of those needs for all of those needs. That's why there's lots of versions of us, right? So in the system, as a case manager, my case manager can go look in there and see, hey, while Tracy was there, these are the things she needed. And she needs to follow up with, in my case, it was a pulmonologist, right? So we need to find her a pulmonologist. So the whole, like, every provider is connected, every PCP in the area, every specialist in the area is connected. Like, imagine it's San Antonio, right? So every provider in the area that are in our network are connected, in addition to all the community agencies. So like the diaper bank, the food bank, transportation vendors, things like that. Everybody else in that, everybody who handles an SDOH need and everybody who handles a clinical need, they can all see it. They can all log in and find out where Tracy is and who's on first. And then as they provide services, say the Texas Diaper Bank logs in, they click the button that says, hey, Tracy said she needed diapers, I'll give her diapers. So then Superior doesn't have to go, hey, let's also try to give her diapers. We know someone else is doing it and we can spend that money on a different resource instead. Now, medical records are flowing in the between, right? So all the clinicians can see, the specialists can see what happened in the hospital, the PCP can see what happened with the specialist. Like, everyone is able to communicate. And this is the first time that we've had that much of an ecosystem around a member, and we can really say, hey, we referred to these places and they had to reply back and tell us if they did anything about it. So we can grade the network and say, who should we not be sending things to because they aren't responsive? Who should we be sending things to because they're very responsive? So yeah, those are my 2, like, I'm launching immediately programs this year.
Woohoo! So I anticipate a big year based on everything that you said, and I don't know if you're looking, but I was taking notes furiously during this because it just seemed to answer 2 major questions, 2 major misses that a lot of organizations have when they're engaging their patient populations. Which, Cass, correct me if I'm wrong, but it sounded like navigation tools for always knowing the next step that you need within your care journey within the health system and plan. And Watershed seemed like it brought in the things that the system might not offer, but helped coordinate resources and identify pathways for patients to be able to take
and assess those partnerships.
Excellent. Well, when also there's another thing that happens when you talk about something that has that many connection points, that many checkpoints. Like, I know that it takes a lot of conversation across the board, from a care navigation perspective, from a clinical perspective, and also from an IT perspective. And what do we have at every step along those ways are myths and ideas that might prevent people from opening up the purse strings and opening up the resources to be able to make those things happen. So when we think about, like, even before something even gets to RFP, before like while we're still coalition building and trying to engage our peers and leaders and things like that, how do you overcome obstacles, or what is, and it doesn't necessarily have to be Centene. I'm just looking for what is your advice for people to be able to start opening these doors among their peer leaders, despite some of the pervasive myths about Medicaid members?
Like my top advice points whenever, because companies ask me these things all the time, right? Because I meet with people frequently who are interested in doing something in this space. And what I start with is, one, you need to find a clinical human. Like, obviously I'm a clinical human. And so I'm passionate about doing these things because it's been my experience. And I want to make things better than what the experience that I had with my kids growing up. And so if you can find somebody, like, I wish I could tell you there's a particular title of a person to go after, right? Come agile. Like, yes, you have a service, but is it necessarily the most effective delivery method when you consider a Medicaid population? Trust us to tell you what's more effective. And so you have to have that cheerleader within the company that's willing to understand. Like when the companies that I described, when they came to me and said, "Hey, we do a thing," I went, "That's a very cool thing. Now, I'm going to do this thing instead." Like, just little tweaks. So if you create a partnership with a clinical person, that's your best step forward in really understanding and going after the barriers that you think are real and the ones that are real.
There's another part that wonders too about perhaps that clinical person who has identified a solution, identified something that they believe can help address the needs for these for a Medicaid population. I'm talking kind of internal to a health plan or to a health system, and they might encounter barriers or blocks or misconceived notions from their peers and other leaders. I wonder if you have ideas or stories about how as someone who's identified an innovation within an organization, like how they can work with their peers who might have objections to what they're trying to do or the resources and money spent to make that innovation happen with their health plan.
Yeah. So how do you do it if you're within a health plan? Like, you're a case manager who wants to do something cool. Like, how do you get past all the barriers inside?
Yeah.
You story tell. Like, you explain where that like what your problem statement was, right? You go to, like, when I first did my first project, right? I started meeting, it was a data project. And so I went to my leadership to explain, hey, doctors are really mad at us when we tell them they aren't, they aren't managing the ER utilization of their members well, and they aren't following up. And we're giving them a report that's 120 days old. Like, how do you, it's reasonable that they would be frustrated with us to tell them to correct something that we can't provide data on. And so that was the beginning of my first use case. And I went to, I had a clinical human as a boss around that time, and then also an operations person. And so I went to both of them, and the ops person, like, stepped up and went, "Okay, this is how you write a business case. Like, it sounds like you have a solution to a problem, but you just don't know how to do that thing." And so we started out figuring out how much ROI, right? It's always money. Money is my least favorite topic, by the way. But you have to figure out what things we can save that will pay for that, right? And so we figured out along the way how many ER visits we might be able to prevent because people didn't go back to the ER because they forgot to continue their meds for their strep throat after the 3-day mark, right? They didn't finish the course. Suddenly they're sick again. They're back in the ER because no one reached out to them to tell them, hey, follow up with your own doctor. Your own doctor is better able to treat you, and you won't have a 12-hour ER wait. Wouldn't that be cool? And so we built out that business case together of the potential savings for investing in a health information exchange. And that, we went through approvals. Luckily, I had a backing of someone that was credible in the operation space, and I was the clinical human. So we built out that business case, and then that taught me along the way how to pay attention in the organization. So have your listening ears on. Like, what things is everybody saying? Oh my gosh, we've gotten in trouble for these things, or these scores aren't as good as they can be. Like for HEDIS, like HEDIS and STARS and CAPS are all really important metrics for health plans. And so if you find a way to target those problems, and your solution works for those problems, then figure out how to measure it. And that will get you past so many boundaries. that you think that you can't get past. Like definitely it's about listening within the organization. And like RFP is one of them, right? I know in an RFP, it's the best time to suggest the innovations that I've been wanting to do for a while. So when that comes up, that's the first thing I do. I go, here's my list on day one. Here's the things I've been wanting to do forever. Tell me which ones you like. I will get them in front of you instantly. So that's typically how I make things work. Is that what you're looking for?
100%. And I hope that you got innovators and people on the tech side to take notes seriously on that part. And you got people working internally in the organizations who want to drive these innovations. I hope they took notes seriously too. So yeah, thanks for helping with both angles there. I know that you're hitting hard right now with regards to navigation, both internal and external. I'm wondering about what you're looking out in the market and saying, I wish there was a solution here. Just this is for people to for innovators out there to maybe plagiarize some of these ideas, but just curious about what would be your wish list for available technologies for helping to address Medicaid.
So I am completely obsessed with teen and child pediatric psychiatry in this moment. Like the gap is so wide, and we just don't have enough, clinicians. We don't have enough partnerships. We don't have there's not enough steps in between, right? Not everybody needs a therapist. Not everybody needs a psychiatrist, right? There's peer support groups, there's digital therapeutics, there's like opportunities for education for in the middle. So even if a member states that, or even if a member like leaves the hospital and we want them to see, follow up with a therapist or psychiatrist, that's once a month, once a week max, right? We want stuff in the middle. Like they can work on coping skills, they can learn ways to manage their mental health in a non-clinical environment. And so I'm looking for, and I've found some, I just haven't figured out the funding for some. So I'm very open to hearing if you have a way to fund peer support groups. It is a payable service through Medicaid, but the reimbursement, unfortunately, is so low. You can barely afford the staff to do the thing. And so I'm looking for a creative way to form a partnership that allows us to maybe do both, right? Like maybe they do the therapy and the psychiatry, but they also have peer support so that the costs get spread across them. I'm not quite sure what the solution is there, but I want to do something for the middle, right? All the moments that you're feeling stressed out and you need someone, something, somehow that isn't necessarily your assigned physician or your assigned clinician. We went in with this assumption that if a child has a behavioral health concern or a mental health concern, they are the only person that needs treatment. And that's not true. Like how much time, like I said, you spend very little time with your actual clinicians in comparison to the reality of how much time there is, right? What about everything else? I mean, do you think that, the mental health problems weren't triggered by something else going on in that family? And don't you think that if we treated the whole family, everyone was learning the coping skills together, they can support that child in continuing the work on the coping skills together. They can all learn to communicate better. There's so much you can learn as a family. And we don't involve parents in treatment enough. We don't teach them along the way. So I really there's a program that I really like that treats, and my favorite line about them, they say they treat birth and up. And I was like, what? How do you do behavioral health at birth? And they do. And so they start by parent training. And they teach parents along the way the things that as they come up, they can learn how to cope with, learn how to support, learn how to navigate. And they're there for them so they can be stronger for their child who needs support for their actual diagnosis. So I want to treat families. Like, help me figure out a way to pay for that.
It makes me think about things like precision behavioral health, which seeks to understand what program, what intervention is going to be the best fit, and perhaps that might not be the in-person talk therapy. There might be other services or other things that's more applicable to. So it does make me wonder though that there's another part to this, which is like you've identified some innovations, you've identified some pathways that you'd like to see out there. What do you use? So you are that clinical person that people should be seeking out and asking questions to. What tells you green light or red light when you're talking to someone who's proposing a particular innovation?
definitely a series of conversations. Like I'll meet someone at a conference, we'll have like a conversation there, and then we continue to talk several times. And so as we're talking, I'm figuring out, one, do you have a history with this? Like me, right? Are you doing this because you saw a problem or experienced a problem and you want to help people because of it? So you really relate to and understand the problem. It's not just a product to you. I'm obsessed with mission-based companies. The first one I ever met taught me that that's the way to go. And that's what helped me define the difference between a partner and a vendor. It's like, if you're mission-based, you're open to learning. That's another thing that I'm obsessed about. If you absolutely just want to sell me the thing in the box, and it only comes in the box and it only does these things, like odds are, if you don't customize, there's not a whole lot we can do together. I also look for, in the past few years, there have been some unfortunate experiences within the whole ecosystem, not me specifically, where companies have come in and said, I really want to do Medicaid, but really have no idea like how complicated it is, and aren't able to manage their bottom line when they figured out that the no-show rate for Medicaid members is often in the 40-50% range if it's just a brick and mortar building. And so people who are open to doing like hybrid approaches, or open to doing what, like I described earlier, like multimodal approaches to using the technology, they'll do better. And so I'm listening for, one, do you have any experience with payers? I need like 3 to 5 years of other payers in most cases, due to some bad actors along the way. And then separately, in Medicaid, do you have at least a year of experience in Medicaid, or do you have leadership that came from a lot of experience with Medicaid and they just happened to show up at your company at this time? So those two can equate. We have piloted historically companies like the first time, like we pilot, so Texas tends to pilot a whole lot of stuff for all of Centene, and then the other health plans kind of chime in. I'm sort of obsessed with pilots because, I got to make that money work, right? And I can't make that money work if I don't have any outcomes. So if you'll pilot with me at little or no cost, then we can prove out your value and a short-term pilot so that I can justify getting you paid for a longer-term project. And so it takes that agility, that flexibility, that willingness to listen and learn and actually be a partner. Those are the things I'm looking for. The things that are required are some experience.
The question that we always like to finish with is, we give you a superpower, a magic wand that allows you to change any one thing. Just one. I know there's many that we need to work on, but just one thing within healthcare. So with that magic power, what would that change be?
I want more collaboration. I want you to not do your work in a box. I want you to, like, this goes for everyone, right? I want you to be willing to understand, like, from payer to payer, Medicaid members can change once a month, right? They can go from Aetna to Superior once a month, and then back and forth and back and forth. And so I want everybody to start to realize that if we just help all Medicaid members across the board, that member is probably going to be our member at some point, and then back and forth, or we're only just helping each other. And so I want us to start to see that and just make it the mission that we just help Medicaid members in general, knowing that in the end, the money will work out. Just little things.
Well, I like the collaboration that we had today in going into having this conversation. Coming out of it very energized, informed, and excited. And I'm guessing that a lot of people who are watching or listening feel the same way. So what's the best way for them to keep track of what you're doing or follow you on social?
You can find me on LinkedIn. I don't do like Twitter or Facebook or any of the others, but you can find me on LinkedIn, and I do a ton of press releases too, so you can always see what I'm up to.
Cool. Y'all, yeah, please keep notice. Again, like, even look at your LinkedIn profile, fierce patient advocate. I think that's just a reminder that like, you're in a director level and leadership role, but like, you're still thinking about the patient. And I think that everybody needs to be reminded to keep the patient at the center of everything that they do and not get too far away from that. So with that, I'm super thankful for everyone who came onto this conversation. Thank you very much. And we'll see you next time.
Thank you.